Good evening to everyone. A very big thanks to AOF and Dr. Lalit Verma for giving me the opportunity to talk about our work with chronic CSCR with central leaks. And why are we discussing this topic? The topic is being discussed because CSCR as a disease, we have not been able to understand the pathogenesis till date, and we have n number of modalities to treat it. And whenever you have n number of modalities to treat a disease, none of them is perfect. So this is how we define CSCR, and it is extremely important to know that what are we talking about when we say chronic CSCR. Many people will like to talk about it as more than 4 months duration has passed, there is poor visual recovery. But this is when the time to act has passed. When we talk prospectively about detecting which of the disease subset is going to go into chronicity, we have to talk about the number of leaks which are present in the initial part. If they are more than one, think of chronicity. And if the RP atrophy is more than 1 disc diameter size or multiple RP atrophy patches like this, then you should start thinking in terms of chronic CSCR and treat accordingly. So when treating, both my learned colleague and I will try to treat the identifiable risk factors. We'll agree that when it is non-central, the way to go is FFA guided laser. But when we are dealing with central CSCR, whether it is acute or chronic, we have multiple modalities available, out of which PDT is not available to us in India today. The only addition which occurs in cases of chronic CSCR is an additional option of intravitreal anti-VEGFs open up. So in all cases which we treat, we look for serum cortisol, we look for nicotine usage, we try to optimize the sleep, the usage of psychoactive agents and obstructive sleep apnea. Once we have taken these risk factors out of the equation, we start talking about these 3 options that we have today. One, as sir has rightly pointed out, micropulse laser, yes, it's an option. And we also have an option of mineral corticoid antagonists like Eplerenone and intravitreal anti-VEGFs. And why there has been no consensus or a well-designed RCT to talk about central serous is because we do not have a gold standard against which we can compare this. The near gold standard is PDT, not available. So the options which we have 2 large trials which stand against the evidence which will be put forward to you today. Though sir has very nicely presented the data on micropulse, but the PLACE trial stands against it. While I'll be talking about Eplerenone, in chronic CSCR, there is a big issue where Vichy trial showed that it does not work. But I'll be telling you something different about prevention of acute CSCR going into chronic. So right after Vichy trial came, there was a quick rebuttal from a group which said that the recommendation made by the group that we should stop treating patients with Eplerenone was too severe, and they questioned the inclusion criteria and the definition of success outcomes by Vichy trial. 62% of Indian practitioners as of 2023 use Eplerenone somewhere in their management of CSCR. And in 2024, we have an Iranian RCT which shows that the best corrected visual acuity change in patients who were started on Eplerenone in CSCR was way better compared to placebo alone. So we have published data on the usage of this. And there is a niche space where Eplerenone has proven itself. It is in acute CSCR conversion to chronic CSCR. This was a pretty large trial with 58 patients which showed that neurosensory detachment settles down much faster when you use Eplerenone. And it also works very well when you have cystoid degeneration in cases of chronic CSCR. So we tried to modify this and we used it in acute CSCR cases. We do not conclusively believe that it works once the disease has gone chronic, but we definitely believe that it prevents prevention of acute CSCR going to chronic CSCR. So we designed a RCT in 2019. We had a CTRI approval and we tried to make the data available for 1 year. Very soon we realized it is too early to comment in CSCR for 1 year data. So the trial was extended to 5-year data with an option of rescue laser. 84 patients had to be recruited to gain significance, and in this subset we realized that at 5-year follow-up the neurosensory detachment duration was much higher in the group which had a placebo treatment compared to Eplerenone treatment. Also, the best corrected visual acuity was a shade better at 0.08 compared to 0.14, but the contrast sensitivity was far better. Also, the perimetry values were greater, and when you look at the total duration of NST over the 5-year period, you realize that it was there for close to about 16 weeks in the placebo group compared to 8 weeks in Eplerenone group. So we believe that Eplerenone is a good agent when you try to target it in acute phase. And how to identify the patients which need treatment in acute phase is based on those multiple leaks which you identify on FFA and the autofluorescence of the patient, which indicate that this particular patient may be trying to go into chronicity. This is the kind of classical case workup we do. We take a detailed history, we check the vision, color and contrast, and we do multimodal imaging for all our patients who are undergoing treatment for CSCR. And octide baseline is always done to rule out any CNVM production. And if the leak is not extrafoveal, we continue treatment with Eplerenone. In this particular case, I will show you that from 6/24, this was the OCT in March 24, by May 24 and September 24, we had a 6/6 visual recovery and preservation of contrast and color. So we talk about using Eplerenone in acute CSC, and there is a well-defined subset when we have thickened choroid, type A personality and raised serum cortisol, where we will strongly advocate for the usage of this drug. Now coming to the evidence for anti-VEGFs. Very recently we had an article talking about brolucizumab in 5 patients only, which said that all of their 5 patients who had chronic CSCR with central leaks, they responded very well to brolucizumab. An Eplerenone trial was done about 7 years back with 10 eyes, which showed moderate improvement. And we also have Chinese data of about 54 patients where they had a 3-armed study, 18 patients in each arm, where we talked about efficacy of brolucizumab more than Eplerenone and PDT. Now, what are the cases where we tried it in our patients? We tried it in 9 of our patients, where we proved on Octa and ICG that there was no CNVM. The leak was within 1000 microns of fovea. And this was one of the cases where right after the first brolucizumab dose, we had a partial response. This was our first patient. And after that, we have seen multiple patients. This is one of the patients who was a cockpit crew, wanted to go back to duty early. He was in 4th month of his CSCR, did not have any CNV evidence. The moment we inject brolucizumab, at day 14, has complete resolution of the subretinal fluid, is able to go back to his duties. We have had 9 such patients in which there is a drying effect in 7 of them, complete drying in 5 such patients. 2 patients have shown partial drying and 2 patients did not respond. And we did not have to repeat brolucizumab in any of these patients. So why we manage medically is because we have enough evidence to show that Eplerenone acts in preventing conversion of acute to chronic, and whenever we are dealing with chronic CSCR which is not responding, we go with brolucizumab. Whenever we talk about any disease entity and its treatment, it is good to listen to the evidence which is published, but it is better to generate your own evidence. So we also have had our experience with micropulse. Though we do not use the yellow laser, we use the green laser for this. The PLACE trial shows that when it is compared to half-dose PDT, the improvement in number of letters is 4.6 with PDT compared to 1.39 in micropulse. In our patients, we had close to about 118 such patients which we have treated. In 91 patients, we gave a single application. In 27 patients, we have had repeat applications. And in all these patients, the best corrected visual acuity improvement has not been very marked. And the RP atrophy does occur in few patients. Though sir has shown very beautifully that in none of his patients there was any visible evidence of any RP destruction. And sometimes, this is something which few of our colleagues may do in their overzealousness, that rather than doing a micropulse, they end up doing visible laser at macula. And this particular patient, once he underwent this kind of laser, definitely the NST subsided, but the patient had hand movement close to face vision. So though micropulse does not have as impressive results as PDT, It can be used in chronic CR. It's an option I like to keep, but in a patient which is presented upfront to me, I will like to treat that patient with eplerenone to prevent his conversion from acute to chronic, and we have brolucizumab as a much effective mode of therapy when we are dealing with chronic CSCR with central leak and with cystoid degeneration. So to close it, we'll not take away the credit from sir for using micropulse. It's a good option, and why not? We'll keep it as an option. But I will like to treat my patients medically using eplerenone and with anti-VEGFs. Thank you, sir.
Thank you, Pradeep, for very nicely defending that. So before I ask the panelists, I will just ask from the audience, because the audience has to be equally participative. Just by show of hands, because it will take 30 seconds, how many of you use micropulse in chronic CSR? Okay, one. Okay. How many of you try medical treatment in? So, Ajay. So you have 1 minute for rebuttal. 1 minute, not more than that.
So the question is, how many of you have micropulse laser? If you have micropulse laser and access to the micropulse laser, you will use it. Second.
Please rebuttal for this. Don't ask.
Okay, all right. So I thank Dr. Pradeep for actually agreeing that micropulse laser works. In his last statement, he said that micropulse laser is an alternative in absence of PDT. So thank you very much for that. Number two, the PLACE trial was basically fallacious because they used standardized treatment of micropulse laser rather than standardizing it for the patient. That was the basic fallacy of PLACE trial. And if you use a standardized treatment, you will be delivering less energy. So it was not compared apple to apple and oranges to oranges. It was not compared properly.
Now 1 minute is for you. That how do you defend? Because what he said was that it is an alternate. It's not a first line of management. First line of management for him is medically, for you is SPML. But what is your rebuttal for him? Will you still, considering whatever data he presented of 34 eyes over so many years, so many sessions, will you still consider SPML as first line?
No, sir. I will tell you why, sir. That one, if we are allowing the disease to go into chronicity and then thinking about treatment with micropulse, it is late. It's a train which has left the station. When we have an option of addressing the disease early, going in with eplerenone, and though you showed that there are significant side effects, the largest trial to date, which is the Vichy trial, which showed that it does not work in the eye, has proven that the systemic side effects of the eplerenone group were actually lower compared to the placebo group, and none of the serious side effects occurred. The 3 deaths which occurred were in the placebo group, not in the eplerenone group. So that is something to
Okay, Pradeep. We'll just have one minute by each panelist. Avinder, what is your take? You want with Ajay or here, right or left? Eplerenone. Any one reason? Mike. So honestly speaking, none of us know what is CSR. None of us know what is CSR. I do not know what pulse is, micropulse, heat shock proteins is all theory. Oh, micro वहाँ RP में क्या करता है वहाँ पे I do not know, but it does something to RP. Yes.
Sir, I think we need to look at the pathophysiology of CSR and choose wisely regarding this versus that.
That's a political statement. That's a political statement. You are
explain.
there or there first.
No, I'll explain that. Now, when we look at chronic CSR, it could be because of choroidal vascular changes, or it could be because of RP underactivity. So, if it is RP underactivity, then tickling the RP, increasing the RP function with micropulse laser seems to be good. Whereas, like if a thermal laser is used to cut the leak and fibrose it and close it, here you are basically tickling the RP to perform better so that the RP pump will take care of the fluid. Whereas, if the basic problem is in the vasculature, like for example there is an increased choroidal vascular pressure which causes the fluid to leak through the and that causes the chronic CSR, then an Eplerenone would be quite
So
better.
what clinical indices will you see?
Yeah.
What clinically you have to give a message there?
So if we have endogenous corticosteroid increase, that would point towards a vascular problem. Whereas when we have a sick RP syndrome or a fluorescent angiography, you have all the RP there which is sick, then probably we will go with a micropulse laser. So both are effective in corresponding types of lesions.
Can I just say one thing?
I will
add with Dr. Gopal what he has said. One clinical parameter with the choroidal thickness is more. I think going with Eplerenone is better because it addresses that issue as well. And obviously the RP part, the laser will be.
Both the points are well taken. Yes, Abhijit.
Yes, sir. I think the first part, problem comes with the micropulse laser because you need some skill to apply the micropulse laser and some training also, and very less of us as an option to us. So if you have to treat the chronic CSR as defined and we don't know what is RP or choroid thickness as per COD with COD, and usually chronic CSR you get choroidal thickness more. That is also studied too. So either you can go to the brolucizumab and the faricimab, which is showing really prospect the studies. Eplerenone you can choose, but different studies they are not that much effective in
Lots of ifs
improving
and buts.
the.
Lots of ifs and buts.
So I think the anti-VEGF may be the first choice I should.
Okay. That's another point. You see, brolucizumab, a lot of people have started using brolucizumab for resistant kind of fluid, any fluid, because it's one of the most powerful drying agents. But there's a lot of fear attached to brolucizumab. A lot of people don't use it at all. Some people use it with caution. So last comment before I ask you the final.
As all the panelists has described it very nicely, so it is very clear that as you told also the CSR we have a very limited knowledge. There are a lot of scope to know the knowledge about it, but there is a vascular component which is definitely there, is playing a role in chronic CSR. So in my opinion, I will prefer go for the Eplerenone, which has a very specific role, easy to use, less skill is needed. For a general ophthalmologist, is much easier to use rather than a micropulse.
How many months of review?
So at least I will work for 2 months and see 3 months.
So last comment we'll have by the chairperson, that is Shubhen.
No, sir. So your comment would be the last comment, but I should say that most of the chronic CSF cases are not chronic CSF at all. It is there is some kind of background component is also there. So I have a limited experience on micropulse laser. The main difficulty with this micropulse laser, the dose adjustment. If you are doing the test dose on the retina, but where we are treating the area, retina is off at that area because the presence of SNF is there. So those adjustments is another difficulty. Number 2, the absorption of the fluid is a little bit slower rather than green laser. Vis-a-vis the green laser. So you will get result in a delayed, after a certain point of time, maybe 1 month, 2 months or 3 months time. But here the Eplerenone, using Eplerenone or if it is not responding, going for the anti-VEGF injection, it will give you definite treatment for if it is not responding, go for the anti-VEGF. So
I thank both the speakers for raising these controversial points. And before Gopal wants a small point, but I agree on one aspect that if PDD was there, both of them said PDD would be preferable. Ajay,
low fluence.
once again, low fluence. If PDD was there, would you still prefer micropulse? One, yes or no?
In presence of PDT, I have still used micropulse.
Okay. If PDD was there, if you have all the 3 options.
PDT. If PDT is available, PDT is first choice.
Last comment is
head-on-head trial against Eplerenone versus micropulse laser, which is published this year, and 44 cases, they found both had good effects over 12 months, and the micropulse laser, the resolution of fluid was faster, but the actual resolution of fluid, the macular thickness reduction was more with Eplerenone.
But I'll go by what Gopal and Matthew said initially, that if EDI for the choroidal vascular is more, there are today methods to measure choroidal vascular pattern, then I think micropulse may be better. Eplerenone may be better. Otherwise, if there is a sick RP, then I think micropulse may be better.
The paper Gopal mentioned, Eplerenone was used for 1 year.
Yeah,
That is
Eplerenone
also
has to be used for a couple of months, and
Yes,
that's
3 months.
electrically done. Electrically done.
once daily. Typically come once daily, at least for 3 months.
2 months, followed by 25 milligram
this, I think we will close this session.